Before we start, we'd just like to acknowledge that this land that we meet on today is the land of the Kaurna people, and that we pay our respect to their relationship to country and as their presence as being custodians of the Greater Adelaide region. So just some housekeeping items before we kick off. The chat will be turned off, but we will have an opportunity at the end. You can start a discussion using the Q&A tab throughout if you just look to the top of your screen. So the first section will be the presentation, which will be recorded, and that's what we will be publishing. Then we'll stop the recording for the Q&A part. So it just gives people a little bit more comfort that they can speak as they wish without the fear of being recorded. So for those of you who are unfamiliar with the Commission on Excellence and Innovation in Health, or the CIH for short, we're the lead agency for innovation in healthcare in South Australia. We love to bring consumers, clinicians and others to collaborate together to turn better ideas into better healthcare. So our vision is together creating health and prosperity for all. And to do this, we're supporting the sector to come together to imagine new ideas for better healthcare. We also acknowledge that better isn't always excellent, but we're committed to measuring what we're doing so that we can understand the impact that we're having and that we're actually making a change. So that's, I guess, the essence of the showcase, is that what we're trying to do is to make sure that all of the information that we have about what's going on in the system is being made aware, and we're trying to build those connections across the sector. It's about sharing our ideas and sharing the innovations that we have available so that everybody can have an opportunity to deploy it. So during the series, approximately 40-minute presentation. It's available online anytime, as I said, because we're recording it. And it is about bringing teams together and providing a space to explore and to be curious about what it is that we're doing and how we might improve it. But at the end of the day, it's about trying to keep it simple and having something manageable as we go forward. So we're always looking for new themes for the series, for the showcase. So if you have a story to tell, if you've got a problem that you've been trying to solve or you've learned something along the way, you may even have themes that you'd like us to explore. So the email address is there on the screen. Please let us know. We're always happy to have a conversation about that. So I'd like to now introduce the theme of our 15th series, which is digital and data-based innovations. We know that innovation and data are interdependent in so many ways, and that the landscape is changing so rapidly. So each of our speakers has been asked to describe the work they do in this space and to demonstrate how this interdependency exists throughout the innovation journey. And just a quick, I guess, shout out in terms of the innovation journey, that some of you may already be aware that we released the innovation model late last year. It's based in the literature, industry consultation, and it aligns to the ISO standards for innovation. So if you're so inclined to want to innovate, please go to our website and have a look. A lot of what's in there, hopefully you'll be hearing throughout this series. So for those who aren't aware, this is the first of 4 presentations. So Michael obviously will be the first speaker today, and then we have other speakers subsequently over the next month. If you hit that QR code, that will give you more information and an opportunity to register. So please forward these links on to others. As I said before, we are trying to collaborate and build our network. So I'd now like to introduce our speaker for the first presentations, Michael Bakker, who is the Chief Pharmacy Information Officer for SA Pharmacy as part of the statewide clinical support services within the Department of Health and Wellbeing. Michael's currently a PhD candidate specialising in human-in-the-loop AI for clinical decision support. He brings over a decade of experience at the intersection of healthcare, technology and strategic system redesign. He's led the statewide digital medicines initiatives and is a recognised leader in the digital health transformation. In his current work, he focuses on how technology can meaningfully support clinicians, improve medication safety and drive sustainable change. So thank you, Michael. Welcome.
Thanks very much, Fraser. I'm very excited to be here, and thank you to everyone coming in today to have us to listen to me talk about this exciting topic for us, which is Automedic. So we're going to start by zooming out, I guess, really far, because this is not just about meds, but healthcare in general. So we're really facing a bit of a tipping point where we all know this, for anybody who's involved in health service delivery, is that demand's rapidly rising. We've got more complicated patients, longer admissions often, more interventions in their care, and that our workforce is already really stretched thin, and the kind of pipeline to go and create new people to staff those beds, those services, those community settings, wherever it is that healthcare is being delivered, is not something that just changes with the click of our fingers. So there is this Deloitte report that was put together a couple of years ago using the Australian National Health Funding Body data. And there's a line in there that really jumps out, which is if healthcare activity overall, not just within our hospitals, continues to grow at the current rate, by 2050, our workforce will need to be providing 4 times the productivity that it has today. So letting that sink in, 4 times as productive is not just 20% more efficient. It's not one nurse doing the job of 2. It's 4 times the amount of activity. It doesn't necessarily equate to needing 4 times the amount of beds or anything like that in our hospitals, but it represents the way that people interact with the whole spectrum of healthcare, whether that's the primary or tertiary care setting and all the other supporting structures. So we've got to ask ourselves in this seminar about digital, do our systems today even let clinicians operate at the current levels of productivity safely? We can't just train more people or stretch our resources further. We can't keep asking clinicians to go faster when the system itself is being built to slow them down. The only way we meet this demand safely is by transforming the way that we deliver many of our tasks and processes that are involved in healthcare. And that starts with systems that really value time. They reduce duplication and enable the kind of quality that we need to see at the scale that it's growing and needed. For those people that have kind of heard me talk, oh, sorry, I'm skipping ahead one of my slides there. So in this juncture of rising demand and increasing standards to the standardization that we expect in our health systems and all of the additional complexity that we have, I think this is going to be a common theme that I'll try to emphasize today, which is around quality systems are not just this nice to have thing when you can afford it. They're really a foundational safety strategy and the only possible way that we're going to get to where we need to be without compromising on care. Because let's just be clear, it's really important that we're not lowering our standards. There's no ethical argument where that could ever be the case and justifiable. So it's about making sure that whatever we're putting in place there is valuing the person time without compromising on care. If you took this statement right now rather than future demand, think about how much time, which is what we're going to go through as the motivator to why it is that we've done Automedic, which is really important for people to know. We're losing a lot of time to human band-aids that due to a lack of system integration and poorly designed workflows, and basically the follow-up of all of the incidents that are created by those systems as well through the investigation processes that are required when problems happen. The write-ups, the interviews, the sick days, the harm, the plan, do, study, act cycles that need to go into all the types of things that go around improving systems when they're not working properly. For those that have listened to me talk before, you may have heard me use these phrases. I'm not original enough to have this long list of them, but I do like to turn a phrase to try and emphasize some points. I'm going to start off with 2 today. So this one is, you can't get to the moon by climbing successively taller trees. It comes back to some stuff when they were doing the Great Space Race back before I was ever born, but I think it really strikes a chord with how we go from we still use a lot of paper-like and paper-based processes to justify the way that we should design our digital systems. While it may form as a really good basis for our minimum expectations, if we constrain ourselves to thinking about processes that were limited by their technology, we will never supersede that effect that paper-based processes could have. So we need to stop using what we used to do to inform what our future expectations or plans should be. And at some point, we need to realize how these views can actually hold us back. And that in terms of digital technology, there can be great leaps that allow us to get into those really improved transformational projects. The second one, and there's a lot of kind of calls to action going around about how we co-design with clinicians. I like this one as well, which is if I'd given people what they wanted, they would have asked for faster horses. Co-design is really important, but it's also important to understand the difference between co-design and participatory design. It's a common thing in healthcare that when people come in with a symptom, we try to identify what the root cause is and treat that. We're not interested in trying to just band-aid problems, but we need to actually treat where the source of the issue is. Pretty fundamental stuff. Digital is no different. We need to ensure that what we're doing are not just band-aids on slightly or poorly performing processes, but there were actually sometimes, on occasion, going back to what is the right way to have done this if we were starting all over again. So there needs to be this healthy to and fro that will foster the trust between the people that are involved in doing this, but will equally focus on finding out what the root cause of an issue is, rather than just that band-aid to a leaky process that can result in errors. So why Automedic then? So let's look at what it's like today on the ground trying to do a simple but critical task, which is a medication history to support accurate and complete management of meds during a hospital admission. We've got a scenario up on the screen here. It's a perfect example of what is an essential but far from efficient process. So in 2025, this is not just for South Australia, but in many ways very similar across all of Australia and in many other jurisdictions. If we look at this as a very common scenario, a patient discharges on a Monday, the number of average medicines that people are on is increasing, particularly those patients with a lot of comorbidities that tend to be our frequent flyers. When they discharge, they continue to take 8 regular and 5 kind of when required medicines for their treatment of their medical conditions. The patient comes back to hospital on a Wednesday, and to identify all of the previous medicines that we used, the treating clinician, the pharmacists involved in this, need to go back and manually populate a list of items from their past admissions, and all of those orders need to be re-entered into the system. It's quite difficult and onerous process. If we don't get medicines right, though, we know that people's comorbidities will not be treated correctly, they'll stay in hospital longer, their outcomes will be poorer. So this process is essential in that if we don't do it, there's pretty negative patient health outcomes as well as an impost on the business. And they're far from efficient because we need to go and search for all of that information. All of this is happening hundreds of times a day in every ward for every clinician and every patient encounter. The real issue here isn't that anybody is rushing through this or that we're missing details. Our people are actually quite good at doing these detailed types of tasks. It's that the system's asking them to do all of the safety work manually. It's not scalable and sustainable with how our health activity will grow over time. The same could be said for dozens and dozens of other processes that happen even more frequently for this, such as medicines administration without barcodes. So why Automedic? It's really about bringing together information availability and continuity to support care. It's about trying to improve that process while acknowledging we need to reduce harm. It's about valuing that clinician's time as much as we do trying to improve safety. The other part is that we're supporting patients and families through their continuous health journey. So it's about the continuity of information and recognising that even when they leave our 4 walls of the hospital or the services that exist outside the building, that we're reducing medication misadventure when they go back into that primary care setting and the role and opportunity that we have in the public sector to be able to do that. So we'll talk about impact here. Now, I've got a lot of access to South Australian figures, but I can help round this out as well. So there's some stats on the page here about the median number of meds that are being charted for patients when they come in. It's about 15 per patient. For those people that went through uni at the same time of me, we used to treat polypharmacy as somewhere in the area of 5 regular medicines and 10 doses per day. That number's increased now because of the number of comorbidities that people have. The sample data that we use for this were people that pharmacy tend to interact with, which generally have a higher med burden anyway. But the average number of meds that an aging and complex person that comes into hospital with now is very high. The approximate time to chart each of these medicines is about 30 seconds to a minute per med if it's really straightforward and we're using all of the quick pick functions that are there. And the number of medication histories that are being performed in our South Australian public hospitals per year is about 87,000. The indicative number of medicine orders on presentation to hospitals is about 4.5 million based on the last look at this. And there's more than 20 million individual doses of medicines administered in the South Australian public hospital sector each year. So if we scale this out and think about this as a national problem, SA makes up about 8% of the nation's population. A quick bit of the back of the napkin math here. If these numbers scale loosely for the other states, it's that more than 63 million medication orders are entered into hospital records at a person cost of around 1 million hours of work per year. The average person works about 2,000 hours a year. So that's the equivalent of nearly 520 full-time medical personnel worth of effort just entering the medication orders into hospital records each year. And that's just one task within a complex web of modern healthcare delivery that, if we made even 50% faster and safer, would provide more than 500,000 person hours of highly trained staff back into the healthcare system. So what about barcode medicines administration for nurses and all the tasks and nitty-gritty things that go into identifying and performing check-in rights and equiting the medicine back in the patient record? Medicines reconciliation for our pharmacists and other clinicians that are involved in that, and clinical documentation for just about everyone. If we clicked our fingers today and said we want 1,000 more doctors, nurses, pharmacists, or whatever other discipline within the system tomorrow, we couldn't do that through training in our universities alone. But process transformation through technology has that kind of power. So medicines reconciliation, I mentioned that we do about 87,000 histories per year. There may be a few that aren't done and documented in this way, but each of these processes take about 30 minutes to an hour to undertake. So we're going to start to zoom in now to what Automedic provides. The steps, for those that aren't familiar with that process, is kind of like the clinician or the pharmacy technician will pull together a bit of a preliminary history, searching through patient records, going to their My Health record, previous hospital admissions, any stuff that the patient has brought in. We then interact with the patient to go and confirm, well, actually, how are they using this? We've got the data, but we need to anchor this in how things are actually being used so that we make sure that we're getting the right things to continue while they're in hospital. It could be that they're doubling or missing out on therapy. We then perform a reconciliation against that history that we've confirmed with the patient to see, well, what is missing in the hospital records? What needs to be charted? What should be stopped? A holistic review of the patient care. We document that and we take action. Depending on the severity of that, it may involve needing to escalate it to the treating medical team, but it also could just be about trying to direct the attention to it at a later stage. So that's a very speed run through what a medicines reconciliation process and history-taking process looks like in our hospitals today. The third impact that we're trying to really look at here with Automedic is around the transition out. So in our South Australian public hospitals, again, we create more than 38,000 medication profiles. A medication profile, for all intents and purposes, is just that list that people carry around with them for a really long time. And what we know that from either anecdotally or the surveys that we've done, this is a really trusted resource. What we often see is that people use this as a bit of a bedrock for their continued medicines management. But when we print it out on paper, it doesn't get updated. It can in the form of people scrawling additions and scrubbing things out off there when it's not up to date, but it's not exactly a way to dynamically update a curated medicines list for that patient over time. Most people, most sites, most jurisdictions in the country are just putting this information into the patient's hand in a printed format. Queensland are a bit of an outlier here. This is data from the Australian Digital Health Agency about how many of these discharge medicines lists that are written for patients are ending up in the patient's My Health record, because there is a section within the My Health record called the Pharmacist Shared Medicine List that it's meant to go into there. For Queensland, though, as an outlier here, it's all a blob. It's just a PDF that goes up against the patient record. There's no ability for the treating GP that manages the patient care in the community or for specialists to update any of that medicines list for the patient. So while it is typically a pharmacist-generated shared medicines list, it's not a curated medicines list that allows people to update this in any way that the consumer would otherwise expect or that they may see in their own applications right now. The other issue that we have here is that these are not shared across jurisdictions when they're created in our systems. The ones that we create in SA sit in our little silo. We know that there's lots of people that come in from Broken Hill and from outside of SA for treatment within our hospitals. And it's really important that those lists aren't just sitting in a paper format that's pinned to the fridge of the patient, but they also exist in a digital format that any of the care providers that the patient would be interacting with can reach in and grab that at their time. With the patient's authorization. So that's the third kind of problem that we're aiming to address with Automedic. So the translation here, before we start getting into more detail of what our innovation actually is is that these are all essential and onerous tasks. So a medication history and reconciliation process is really heavily reliant on highly trained clinicians that are actually very good at manually searching through disparate and incomplete data sources. They piece together this best possible, what is the patient actually doing there? But those processes are all quite manual. The problem that we have here is that we're also expending all of that effort before we identify whether the need was there. I think that I have another slide coming up that just helps to understand that a little bit better, but which I'll get to in a second. The medication review process is really heavily reliant. So when a patient's in hospital, they're here for a few days, and we need to go and search again through troves of data that exist in the patient record, looking for things that may be important to the care. These are a mixture of searching for the presence and the absence of information. So, for example, the presence of information is like have two criteria been met. Again, our staff are really heavily trained in this area and generally pretty good at picking it up with a decent amount of experience. So have criteria been met? Drug-drug interactions, potential adverse effects, those sorts of things. The harder ones to find are like, has something been missed? So it could be the absence of therapeutic drug monitoring where it should have been indicated for a patient. Meds that the patient should have been on, that in the absence of those, their management of their comorbidities will be poorer. And at the transition of care, we're really talking about how do we get this gold standard into something even more, that we're engaging the rest of the health system and not siloing the data that's related to our patient care when they are our patients away from those people that continue to provide care for them back into the community and their other trusted carers. So practically, let's have a look at that. A quick dive into the limitations of our field of view that we have over our patients at the moment. So if two identical patients were admitted to hospital for the same reason, so let's just call them twins, patient one has complex medicines and did not present to hospital with enough information to allow the treating clinician to chart medicines. Many of the medicines are not charted in the EMR, whereas patient two has complex medicines, but came prepared with detailed and up-to-date medicines list, whether that's they came from an aged care facility or they had that recent medicines list, and the clinician has all the information that they need there to chart the medicines accurately. At a surface level, based on the kind of tools that we build at the moment, that's where their field of view is limited just to the EMR, patient two would appear to be the more complex person. But in reality, we could spend all of that effort doing that reconciliation and review for them and find that there was nothing that we needed to intervene on and change related to their therapy. Patient one could take some time and in that meantime not be receiving the kind of care that they needed to be, leading to that deterioration in their management. So that's the challenge for us, is that how do we treat the absence of information with the same severity or more than what the presence of information would be? Before we start to get really deep into Automedic then and our solution, this is about what is our overarching objective. So well over 1 million person hours are lost to manual tasks supporting medicines utilisation across our hospital admission. Each of these is an essential but onerous task. They're human band-aids for a lack of system integration. And to date, all the tools that we've tried to address this have failed or not kind of got to the level that people expect them to, because they lack that context about how clinicians really make decisions to intervene into medicines management. And the fundamental issue here, getting to that root cause part, is one of work design, not safety. Our highly trained people are very good at finding these scenarios and acting on them, acting on that problem in a very prompt manner when they can identify it. It's if the amount of activity in the health system is set to grow to 4 times to the current level, how do we keep up or appropriately address the root issue while not just in the context of that increasing demand? So here's Automedic then. What we're aiming to do here is around better information to improve those medicine-related outcomes for patients, but also the caregivers around them. So Automedic for us is a digital tool that's designed to support the reconciliation and review processes and tasks that are actually involved in it. It's going to sit as a layer on top of a hospital EMR. So in South Australia, that for us is Sunrise, with connectivity to the patient's My Health record. So although the medicines that someone is on varies from person to person and how they take it, the data sources that we access are quite consistent throughout each of our processes that we go through. What we're aiming to do is to reduce the amount of manual effort. We want to try and get more time dedicated to patient-facing activities to make it safer for our patients and more sustainable for our workforce. So Flinders University is the lead agency with this one in partnership with us in SA Pharmacy, as well as UniSA and Adelaide University through the Australian Institute for Machine Learning. We were lucky enough to receive a Medical Research Future Fund grant to develop the Automedic software and to evaluate its impact in our services. So going into our journey then, now that we've gone quite thoroughly, maybe for some, through why it is that we're doing this, how we're getting there is just as important. So our aims here are to design a scalable system. So we start with a process of co-design. I was talking about that earlier, about what that entails. There's lots of information about as to what that looks like. But given that we are addressing fundamentally a work design issue here, we need to ensure that we properly understand this. So the co-design process, which I'll talk through in a little bit more detail, starts at the beginning with an intent to then look at a pilot period where we really make sure about, is the software working as we intend it to, before starting to scale up into a proper randomised controlled trial across 6 sites in metropolitan hospitals in South Australia. Designing scalable systems can mean a few things. It's also not to overcomplicate it at the beginning. So it means that there is a part of this system that has a predictive model in there. But to begin with, we'll start with a rules-based algorithm where there's a few things that we know, and having a proper methodology to grow that understanding of what the problem is over time. So SA Pharmacy, my organisation, we had an existing business logic that we understood as to generally a consensus scoring model as to how people identify the patients that they want to see. We have supplemented that with a literature review through University of South Australia. That was an umbrella review looking at, well, for all of the other work that's been done around prioritising patient care related to medicines-related harm, what are the factors that they identified in there so that we can have a more rigorous approach to understanding this. So that's been performed at the moment and is currently awaiting publication. And then there's a process that we understand in introducing artificial intelligence, predictive modelling into our workforce, that there's lots of things that go along with that. What we need to ensure and what we will be doing is to try and build the trust and a continuous quality improvement process around that model, not only just to monitor its performance, but to ensure that we actually understand what the problem is, because that changes over time. And then there's the other part of it around software design and development. So co-design for and with the people who know the problem and the process that we need to have, broadly applying that to predictive modelling as well, so that we can make sure that we get the model inputs and the features that we're considering as part of this aligned with how people actually make decisions. Because whether we have it documented or not, there's an extraordinary amount of behavioural heuristics that go into people and their work already. And so we're not trying to demonstrate a superiority to that. We're trying to meet it as to how people work and just make the work design process more efficient and more scalable for our staff. And then when we get to the nitty-gritty end of it is that pilot, the predictive model development and implementation process, and aligning that with modern expectations around safe implementation of AI or the Salient framework, and then doing that in a clinical trial so that we can actually get the evidence to demonstrate the impact of this software and over time. So co-design, to run you through what that looked like for us, because people may go, well, that sounds great, Michael, how do we do that? So being a process that's backed by an MRFF grant, we've got to be really rigorous around our planning and evaluation processes here, as all innovations should, but equally because of the research component to this, there is some interest in how we could do this as a bit of a template to further software in the future. So co-design for us looked like having contributions from more than 50 participants across a number of sessions, where we did this in what we called waves. So we started off looking at process mapping and pain points and the current tools that people use and the limitations, really starting to wish list, what the requirements were for them. We did this with a professional UI designer. So there was really someone in the room facilitating that feedback with our clinicians to, ask the whys of understanding why it is that people perform tasks in the order that they do. It gives you that insight that's difficult to get when people have a lot of assumptions about things that if we were having these conversations entirely internally, we might limit ourselves too much. So we mocked up a design there, a wireframe of sorts, to be able to get design input and feedback from the people. It's really important when you're trying to transform stuff with digital technology that people have got to want to use the platform. All the best predictive model suggestions in the world won't work if people aren't engaging in the platform. So there was a bit of a recognition in our process here that we needed to spend the time on the aesthetics and the design to ensure that we had something that was fit for purpose and engaging, that people would actually anchor their workflows in here. From there, we started to expand out the consultation, because while we were getting those people at the coalface and their understanding of the problem, there's also an enormous amount of wisdom that will come to what the problem is and what the impacts of it are that come from other members of the team. So we included consumers in this to help make sure that we were getting their stories, service managers, and also some nursing staff that helped us to recognise that pharmacists are not the only ones performing this. It was really important that we did consult with other people, so that if we got to a point where Automedic is a successful program, that it may not just be a tool that's in the hands of pharmacy, but it could be useful to many different settings and many different disciplines if we can get it to that level of being able to support the process in a trustworthy way. Our next step, which we're about to embark on in the next couple of months, is the pilot. So this is a small-scale deployment of about 25 staff working in teams or individuals, because it's important to be able to cater for both of those, and operating across where our future trial sites will be. So we're picking the areas quite tactically, because we know from the previous attempts that have been done either locally or abroad around trying to prioritise patient care in meds, is that there's a lot of constraints as to thinking that it may only work in the general medical or general surgical areas. So we're trying to tackle that here to say, well, actually, when you have a more full suite system rather than just a scoring model, is it possible to cater for those needs in subacute or urgent care settings that is quite useful. We're seeing an increase in growth in the number of our pharmacy services that are working in a hub and spoke model through a virtual capacity. And so they're a particularly important group for us here as well, where the pharmacists are playing a key role. So we'll make sure that we've got this tool really being shaken down across a number of the settings, the real world settings that we anticipate this will be used with. This pilot gives us a chance to check that the software is actually working in real workflows and meeting what the business requirements are. It gives us that chance to silently deploy the predictive model. For those that aren't as familiar with what the Salient framework encourages, it's about the safe implementation of AI and recognizing that what may be a training and then testing data set, you need to kind of put this against prospective data as well. So there's a little bit more to that if people want to understand more of what that process will be. I've got my contact details at the end here that I'd be happy to talk in more detail, but probably a bit too nitty-gritty for today. And then it's that part of, well, how do we actually use this pilot to understand what the things are that people are concerned about or want to explore, that we maximize the adoption of the tool and minimize non-adoption. Technology adoption, all the literature supports this, is not just about building the best tool. It's also about making sure that we support people. There's lots of frameworks out there that reiterate the need to consider all of the training and onboarding, the cultural elements of bringing people onto a new system. That's really what our pilot phase is about as well, is making sure that we understand what the challenge ahead will be for us and how we plan to tackle that when we're trying to go from 25 to 250 to 600 users across our sites. And then the trial, the big part of all of this. So it will involve utilisation by 600 odd pharmacy clinicians within our sites across Naarlen, Saarlen and Carlin. We'll be evaluating the impact of the software to patient health outcomes, as well as the healthcare service delivery and that operational improvement. Throughout that process, we then develop a scale-up plan as well, because we're not connecting all of our sites in here. We do have a lot of sites that sit out of that. we need to ensure that we can meet that demand, but we start with a control group throughout this. So in the stepped wedge model that we're taking here, each site is brought on in their little cohort, or for some of our bigger hospitals, they'll be quite large, but it allows us to just iterate through this, and it's not dissimilar to how any of the rollouts of EMRs or other technologies otherwise work as well. I want to take you on a bit of a speed run through what is Automedic now, because I may have interested people to understand, well, what is it, Michael? Just get to the point of showing us what it is that you've got here. So I'm going to take you through a few of our wireframes that we've got so that you can get a bit of a sneak peek behind the curtain as to what we're looking at here. So the landing page for patients, there's far more to this system than what I will show you today, but just to give you that quick run through, the landing page is not dissimilar to how people otherwise manage a medicines list in whatever EMR they're familiar with using. It's been made deliberately that way. Familiarity is really important when people are adopting a new system. And what we're trying to do is minimize and make that as an easy as a process. But what we also heard from people is that there's key data elements that they are looking for that they can't currently get from the EMR or exist outside of it, that they would like to have pulled through into a quick view of the patient. So what I've highlighted as a couple of things on here is that, for all of the bells and whistles and attention that talking about AI can bring to a project, for us, it's actually a very small component of this. So on the left-hand side of the screen there, what you can see is that we're making predictions around the urgency and complexity that we think is there related to the patient. So if we're getting through the predictive model that's there, a flag back saying that this person needs to be seen today, we can demonstrate that to the person. And equally, if there's people like the practical scenario that I was showing you before, where we think there's no value to the intervention into care because the medicines look fine compared to what they normally take, and the clinical scenarios that are also features of how this model works aren't firing, then we can de-escalate the need for someone to see them. So we never call someone as not needing to be seen, but we can flag differences in urgency. The next logical part that comes up there for anybody that reads literature in this area is around explainability. So what we have on the right-hand side of screen is that if you click on the priority flag that is in the patient list, you'll be presented with what these review triggers are. So what is it that the event triggers that are actually in an explainable way firing for this patient, so that we can come in and go, well, I want to understand for Hannah, why is it that I'm being called to see her? If I'm comparing several patients that have all got today flagged on there, I'm going to want to use my professional discretion to say, well, who is it amongst that high priority group that actually needs to be seen first? The key part for us and this continuous quality improvement process is to glean feedback from the users in the process of looking at these suggestions as to how accurate they are. They can either do that labeling as they go, or they can do that retrospectively. So let's say this said to them, you have to go and see Hannah straight away. But after investigation, I find, no, I didn't need to see that person. I can provide that feedback into here. And we, as the investigators of the research that relates to this, can go, these suggestions, these features were found to not be people were continuously telling us that these were patients that didn't need to be seen, and we can more deeply understand what the common features are for those kinds of reports coming back. And equally, if someone is being asked to go and see a patient, or they identify they need to see a patient who has otherwise been flagged by the model as not urgent, they can provide that feedback. Maybe it is that we haven't got the clinical features that need to be there from the patient record to properly identify them. There's always new drugs. There's always a deeper understanding right on the next day about what it is that constitutes a patient being complex and the urgency of needing to intervene in their care. So a recognition of that is we need to build this pipeline for people to be able to review the quality of the suggestions being made and feed that back to us as either researchers when we're during the project phase of this, or as an organisation who wants to monitor the safety around the implementation of AI within our service. So there is an awful lot more that goes into that, what we call our audit methodology, that I, again, am happy to catch up with people who are interested in that area at a later time. This will be aligned while I'm presenting this all on the screen here, that you can see all these things on day one. the safe implementation of AI, we will adhere to not showing them in a prospective way to begin with, but people would be providing suggestions back retrospectively against patient records for us and helping us to build that better quality model over time. The second part that I'll give you the sneak peek around then is that reconciliation process. So for me, if I'm going in to perform a medication history, I go back through the patient dispensing records. I look at the past admissions, and what you're seeing on screen here is there's no AI to this. This is just good narrative design around some pretty charts and how they could work. So what we have here, and I've flagged the apixaban that you see on screen, is that the blue dots in each of the months, so let's pretend this is August. The blue dots that you see on each of the months are the previous dispensing records. Now, these are all nicely spaced for that apixaban. We can see that there is a regular dispensing interval of around 1 month for apixaban 5 milligrams. And in May, the person had a hospital admission. That's what that grey flagging means. The blue tick that is there means that they were charted for apixaban 5 milligrams. So there was nothing to see here in that admission. It looked like they were on 5 milligram twice a day. And in May, they were charted for 5 milligrams twice a day. And similarly, in July, that was their previous admission. On this admission in August, the one that's most recent is here, what we have is a flag. And the reason that we had a flag is that apixaban 2.5 milligram is what has been charted for the patient. Now, there could be perfectly justifiable reasons as to why this patient has had their dose decrease. So we're not saying that this is immediately needing to be addressed or suggesting that this has changed. What we're saying is that there's something that is a discrepancy between what we expected and what we are seeing. We would like someone to review that. So I haven't got up an interactive format for you here, but what we can do is to click on that little shield with the bell there, and that will give us the ability to provide feedback on that alert. Again, as researchers, we want to understand more about this problem. And so we may be able to say, no, this was totally relevant, or this is not an appropriate recommendation, or maybe the way that we have matched the directions that are in the patient's record from My Health Record, where we're pulling this information in from, and with the hospital EMR, maybe the way that we're matching those directions is not quite getting all scenarios that we want to review that. So there's an ability for clinicians to provide feedback, but equally to say, I don't want to have this alert happening anymore, suppress. Because the last thing that we want to do is to have a patient get reviewed and continue to have all of these scenarios and features firing off, and otherwise the model telling us this person's urgent to see, this person's urgent to see, if nothing's changed since the last time that I saw them. So the way that these will work then is to allow a person to suppress these, to say, all right, I acknowledge that the apixaban has changed. However, it's clinically appropriate. This is not a clinical scenario that should lead to firing off, saying that the patient is needing a review. If we considered some other scenarios here, the way that this information is presented helps us to do a much faster preliminary history for a person. So if these dots were more scattered, I may be able to walk straight into the patient and say, Hannah, I can see that your dispensing interval for your apixaban is really irregular. Has your doctor been changing that? Like, how do you take this at home, using all of those proper techniques that we do with the patient to get to this? But instead of having to go back through troves of raw data and looking at all of the date intervals and deciding that ourselves, by presenting this in a really narrative format, it can speed run someone through to the process of being able to get to that patient and have the conversation. If we get this right, instead of maybe doing that preliminary history by manually searching through different data sources, maybe people just have Automedic up on their device and they're going straight into talking to the patient and can actually use it as an aid with the patient to say, see, you see your dispensing records here. And how they're irregular or what medicines they've been taking. And it can be a platform to getting straight to the conversation and potentially disrupting a whole portion of what would be an established med-rec and review process that we do currently. Some quick little run-throughs here of the other bits, because I'm conscious of the time that I'll be using up for everyone today. We have our task is also around documentation. We recognise that people needing to put all the keystrokes in to write information back to the EMR about the summary of the changes to medicines, is that as people are acknowledging the alerts that were in the system and otherwise saying, you know, this is held or whatever the case may be, we can pre-fill that information into a reconciliation summary that someone is able to copy and paste into a discharge summary into their clinical documentation within the EMR. And so in this simple little example there, you've probably got 300 to 400 keystrokes that have been made by someone that we can just automate. Maybe they still have to perfect this list, so we're pre-filling it for them, but they may need to perfect the list. But we're not trying to eradicate the process and have a perfect reconciliation summary here. What we're recognizing is that time is the thing that we're trying to address. And so as a work design, by pre-populating this information, it gives you the ability to put it in there, change the things around by clicking and dragging and dropping, and it may be a much better experience for our users and get through to the next patient a bit faster. The other bells and whistles that we have in the platform that we heard from people are things that really need to be in there to help manage work efficiently around notifications. So seeing what's changed with patients, the flags that we have within our EMR are quite limited to being able to see what are the things that are waiting for us to come and review. And equally, the ability to manage tasks separate to consults that otherwise already exist in the system. We've seen over the time that we've adopted EMR within our workforce a continual want for people to be scrawling things down on paper printouts of their patient list for things that could be very easily adopted into a digital task manager. There's barely a person I know that doesn't use flagged emails or Microsoft To Do or something like that to manage their tasks in a day now. Similarly, in our electronic health records, we need that kind of functionality, but equally, we need to be able to pass that to other people so that if Michael was off work today and someone was coming in to replace me, that they can very easily see the task list assigned to me and pick up that work as someone who may be covering for that role during the day. So all crucial things that people told us are pain points in the existing system, but are possible to deliver in a third-party system once we've got their workflows anchored in there. And I guess the last part of what we're trying to aim to achieve here is that whole medication list process. So at the moment, we generate our lists in a system that is entirely separate to Sunrise and needing to re-enter all of that information in. That's very similar in a lot of other states as well, because either the list generated within the EMR are imperfect, or there's lots of things that patients are on that aren't in the EMR as well, that they have to re-enter it themselves. So we're integrating all of those workflows into here and putting that into a way that a consumer will be able to access that list in an ongoing digital way. What we hope to see happen, and we're in conversations more broadly with the Australian Digital Health Agency and players in that area, is around how, instead of us owning this list, maybe a curated medicines list where a patient is able to nominate people that are able to interact with their record. If that is a carer or a parent or someone like that, that's pretty sensible. But if you were actually saying, well, I want my community pharmacy to update this medicines list for me, is getting away from that paper form that gets written on to be updated, and otherwise being an integrated and shareable record that the patient can take with them to whatever episodes of care it is that they're going to, because we've got a trove of feedback that tells us that patients don't take these lists through because having it pinned to their fridge is not the same as having it in their pocket. Well, this puts it into their pocket and it gives them the ability to share it with people that they trust in a digital format and to get people to help contribute to it. And what you're seeing on here is that a possibility of where we're headed with that. So the ability, once shared, to have something as verified. So if I'm a community pharmacist performing a medication review or meds check for a patient, is that I can, validate that the medicines list that they are on, that I'm committing in there now, is their current record of what it is that they're taking. Similarly, a GP or a specialist may be able to do that. And looking at how we can integrate this. And again, in a way, some of these things are already available where people have medicines dispensed and they're prompted to add them into there. But we want to really tackle that properly and working with a more, agnostic platform where we're trying to connect to the patient's My Health record, as opposed to being SA Health's repository of patient medicine lists. So where we started, just to kind of start summarizing all of this together now, is that our objective when we started this is how are we able to meet the growing demand related to the identification and intervention in complex medicines related harm that happens during hospitalization and transitions of care. We need to do that in a way that recognises the internal and external contributors to that problem. So our solution then is to use research to support the co-design, development, implementation, and evaluation of a fit-for-purpose tool for the provision of the work activities that go into that. behind the scenes, there's lots that go into this. So I don't want to pretend like this all just comes together without a lot of work. Is that because this is a research-backed process, there is a lot of ethics and research activities, ethics, approvals and research governance activities that we need to undertake. So while we are building software that might otherwise constitute a more kind of traditional software as a service being provided by a supplier out there, all of the evaluation is really deep. All of the process that we're going through to build this, we're really interested in how the co-design process works and the feedback to that we get from people who are engaging in it. So there is a way or a need to compartmentalize the bits and pieces that we're doing to understand, well, what is software delivery and infrastructure requirements for the software to work, and what is a research activity. And that's challenging. I'm not going to shy away from that. Is to make sure that everybody is singing from the same hymn sheet. There is a continual piece of work, but it's really to get something to come into existence that otherwise hasn't been there before. These are the types of things that you need to be able to navigate, and sticking to what the scope is for your project is also really crucial, so as to not take too many wrong turns. I'll start to finish up there. I will acknowledge that the parties that I mentioned before and all the contributors that we've had along the way here in Flinders University, University of Adelaide, UniSA, the Digital Health SA is a key party in all of this, and we were very grateful for all their tremendous support throughout the Automedic project, as well as the Department of Health as well. I'll leave you with a final thought, because I like to turn a phrase, as you would have got at the beginning. So Jevons paradox is something that has really vibed with me lately, which is increasing efficiency in a system increases demand for that resource. So this isn't about decreasing the presence of a workforce or their impact. It is about recognition that we can't safely meet the demand of healthcare service delivery into the future, and doing it in the way that we've always done it is not going to be able to get us there. There is a lot of emerging evidence that radiologists, for all of the early AI that was put into there, didn't all of a sudden have 1/5 the work of what they were doing before. Quite conversely, they see far more people during the day, because the work design, the work requirements required to support those patients and see them became lower when they had the assistive technologies available to them. My details are up on the screen here. If you want to get in contact, you can find me on LinkedIn. I try to be a little bit active there. Otherwise, my email with SA Pharmacy is there, and I'm very happy to talk to anyone that would like to pick my brain about anything more that we've done in here.
Thank you, Michael. That clearly the work that you're doing has the potential to be a game changer, from a safety and efficiency point of view. So thank you so much for your insight in showcasing the work you're doing.